Okay, so I say good morning. This is Dr. Rutledge, and I'm here with two of my
Good
very
morning, sir.
close friends, my associates from Pakistan. And so I'll turn it over to them, if you will. Can I ask for you to introduce yourself to the group who'll be watching this morning?
Okay, thank you, Dr. Rutledge. It's nice seeing you and early in the morning here in Pakistan and India both. My name is Dr. Aatif and this is with me Dr. Shahbaz Kasi. He is a dual person today. He will be sitting here as a nutritionist as well. He's part of my bariatric surgery team, and that is established in Islamabad, Ali Medical Center and Pakistan Institute of Medical Sciences. And he has been working with me for the last 3 years. And once again, thank you, Dr. Rutledge. And it takes me to 3 years back when you came to Pakistan and you introduced me to mini gastric bypass, which is a wonderful gift to the humanity if I consider for the treatment of obesity, diabetes, and a wonderful bariatric surgery operation. And it was a really pleasure that when you were in Pakistan, we operated together. You told me the nuances about the mini gastric bypass, how it should be done, and it was wonderful experience. And furthermore, I would like to say that Dr. Shahbaz, who is also a nutritionist with me, he's a qualified nutritionist. He was a medical student when I operated him and did his laparoscopic sleeve gastrectomy. And he did very well for the first 3 years. It's just this year, the fourth year of his sleeve or the fifth year, when now he is having weight regain issues, which is very common after laparoscopic sleeve gastrectomies. And in my patient also, this is now increasing every year or every month. I'm finding new and new patients which are operated 5 years or 6 years back. Now they are having weight regain issues. So I would like to talk about Dr. Shahbaz weight regain issue, how we are going to do it. Being a qualified nutritionist, he has been trying all sort of nutritional diets for the last 6 to 8 months, and I have seen him, and nothing is working. He is gradually increasing his weight. Nowadays, he is more than 32 BMI, and his BMI is ever increasing. So I would like your guidance. What should we do in such a scenario? And if we want to choose gastric bypass as a revisional tool for laparoscopic sleeve gastrectomy, what should be done, and what are the things for him in particular we need to know as a surgeon and both as patients out there who might be watching us later on when you record this video, what should be done and how MGB should be done in it. Dr. Shahbaz, would you like to say a few things before Dr. Rutledge starts?
I would like to add to the fact, sir, that it has been progressive. The weight gain post sleeve has been progressive, and it has increased about 19 kilograms. That was more than 35% of the excess weight loss uh, post sleeve. And once you mentioned that sleeve induces a pathological pattern of eating, and that has been well established because carbohydrates are well tolerated.
Yes.
Proteins and the high fiber foods are less well tolerated, and they kind of get stuck.
Yeah.
So the food choices, they change. First 2 or 3 years, yes, it's easy to take protein shakes and uh, well foods that are proteinaceous but are readily digested, like chicken liver or pulses or soupy foods. But as you gradually move on to more solid intake, your preferences change from a high protein to a high carb diet. So I would like to take your input on that, sir.
Well, you brought up uh, very many important and good topics that are worth talking about. And so, but first, again, I'd like to emphasize the joy that I felt in visiting Islamabad and then when we met in Karachi. I would comment to those viewers that Dr. Aatif's program in PIMS, the Pakistan Institute of Medical Sciences, and his private practice demonstrate superb bariatric surgery for patients from Pakistan, but also international patients as well. And his skill and outcome, I've had the blessings to speak directly with his patients now who over several hundred patients and with excellent outcomes. So my congratulations on the safe institution of a new bariatric program using, particularly not a new program, but a new program using MGB. And so my congratulations to you, my thanks to you. And for those of you who are interested in getting in touch with Dr. Aatif, how is best for patients or other surgeons? How is best for them to contact you, sir?
Sir, they can contact me at Ali Medical Center, which is in heart of Islamabad, F8 Markers. And the telephone number which they can WhatsApp or they can call is 0336 598 0125. You have to dial, if you're calling from outside, you have to dial +92. So it will be +92
And
336.
maybe we will put that in the
Yeah,
attachment as well. And
yeah,
is it all right if we put we will put maybe your email address and
exactly.
some other contact information. So if people want to contact you, especially people from Pakistan, but international patients as well, yes?
Yes, exactly, sir.
Good. And that's great. And we will have more videos. We will do some demonstration operations. We will talk about difficult cases. So we look forward to this being a beginning of a good friendship and online sharing using the Zoom technique. And maybe we will invite other patients as well. What do you think?
So that is a wonderful idea, and I am encouraging my patients, whether they have not undergone surgery or even they have undergone surgery, to consult with you, because you have a wonderful experience of now more than around, I think, 23 or 24 years. That in 1997 you started MGB. You were the first person. You were one of the very few persons who was doing laparoscopic Roux-en-Y gastric bypass in early 1990s. So, and people and some of my patients have really benefited from your talks and talking to you directly as well, sir. You're doing a wonderful job for the humanity, sir.
Oh, you're very kind. Okay, so we're going to talk a little bit, it sounds like, about the sleeve and the fact that it's a good operation. But many people felt the lap band was a good operation. And then we learned that the lap band, although it was simple and relatively safe, over the long term, it's been pretty much given up. It's been abandoned. So the band has been abandoned. Um, and I think there's a possibility that there is some similarities between the lap band and its mechanism of action and the sleeve. And so maybe apropos Dr. Shahbaz's questions, I will talk about that for a moment, if I may.
Yes, please, sir.
Okay, so the mechanism of action, I think, makes perfect sense for the lap band, the old vertical banded gastroplasty, and the sleeve, which is partial obstruction. And so we would know that from our general surgery, it's the equivalent of an esophageal stricture. An esophageal stricture, either from cancer or benign, leads a patient to be profoundly thin and frequently malnourished. They have trouble eating a normal, healthy diet. And that's where I think the sleeve and the lap band tend to get confusing, because over time, it actually teaches the patient to eat pathologically. And so I have a slide presentation, and it shows a picture of an apple, a broccoli, and a sandwich. And those are difficult to a sleeve patient and a lap band patient, because that bulky material, when you swallow it, comes down and runs into the partial obstruction of the lap band or the pylorus with the narrow gastric pouch. So that over time, frequent events of nausea, pain, and discomfort leads the sleeve or the lap band patient to inevitably choose foods that will go easily through the obstruction. And of course, we can recall from our clinical management of an esophageal stricture or an esophageal cancer patient, we would modify moving towards liquid calories. And liquid calories routinely are not very healthy. They're Coca-Cola, ice cream, candy. And so what happens is, as the diet is forced more in that direction, even against your will, kind of over the years, we've seen exactly what is described here by Dr. Shahbaz, is superb outcomes or comparable outcomes in the sleeve for the first 2 or 3 years. But over time, the taste, the behavior is forced daily, hourly almost, into this pathologic eating. It also brings up then the discussion about the mini gastric bypass. I have seen just this morning a video of someone creating a mini gastric bypass, but making it much more like a Roux-en-Y, narrow, partially obstructed pouch with a tight, narrow gastrojejunectomy. So they're recreating some of the, what I would call pathologic anatomy that mirrors the lap band, the vertical banded gastroplasty, and the sleeve. So they are thinking that the mechanism of MGB is obstructive. And so they create what they are calling MGB, and they have patients then who postoperatively have nausea, vomiting, and ultimately are pushed again towards pathologic eating because the anatomic creation of the MGB is not conducive to a healthy diet. So that's kind of the difference. And again, that's why I think that we're seeing this description that you've done so well this morning, describing the changes that occur with the sleeve over time. It's a pathologic obstruction, and people lose weight from it, but ultimately they get around it. So that brings us then to talk a little bit about the difference and how the mechanism of action of the MGB, and then maybe, if you agree, we'll go on to discuss the management of the failed sleeve being converted to an MGB. So I'll pause for a second. Would that be acceptable now?
Yes, sir. That is wonderful, sir. And I just want to repeat that I've seen a lot of videos on internet claiming it to be mini gastric bypass or one anastomosis gastric bypass, and then they do not adhere to the principles of the surgery. They try to create a sleeved bypass or a Roux-en-Y gastric bypass, and when then they get bad results, they blame the procedure, which is not right. And that is why you came up with the wonderful idea of training the surgeons with MGB review crop and bronze, silver, and gold medals. But that will be a very lengthy topic. So let's come back again. Now, Shahbaz, you need to say this is your 5th year after sleep that you are now gaining weight. Yes. For the first 3.5 years, he did well.
Yes.
For the last one, he's having now an uphill task, maintaining his weight and avoiding the pathological eating. As you said, the energy dense foods. So, sir, over to you, sir.
So let me bring up, you brought up some topics before we go into more of the details, but let's say a couple of things. One is good operation, bad operation. Good operation, bad operation. The data coming in on the sleeve is now several years old. And what we're seeing is this is not a patient failure. Okay, and I think that patients who are listening to this, of course, Dr. Shahbaz knows this. He is skilled, he's knowledgeable, he's trained in this area. The failure is not the patient's fault. And I see many surgeons blaming their sleeve patients for their failure. It's not that. You have a pathologic situation, and the initial choice, the failure of the lap band, was not a failure of patients who had the lap band. It was a failure about our decisions to choose an operation that could have been better. And I believe, personally, the sleeve is going to show the same thing. That brings up a recent paper from Dr. Prager in Vienna. He looked at his 10-year data of sleeves, and I think it's instructive. 1 out of every 3 of his patients has been reoperated on for failure, and 2/3 of his patients have gained their weight back. Okay, that combination tells us, I think, we have to be very skeptical about the long-term results of the sleeve, but whatever we do, we should not be blaming the patient. I think it looks like that there is an inherent, what I would keep using the word pathologic flaw in the approach to the anatomy and the ultimate outcome, the physiology of the sleeve. The other thing is we can bring up 2 other papers just to discuss, and one is the Y-omega trial. The Y-omega trial is a controlled, prospective, randomized trial where the group of surgeons doing the MGB clearly demonstrate they're not very good MGB surgeons. And what I mean by that, they demonstrated their outcomes were quite bad. That is, they had high incidence of revisions of MGB early, within even 1 year after the surgery. So to me, that demonstrates that either the MGB is bad or the surgeons and their technique was bad. So that brings up the 3rd paper. For those who are interested in looking it up, it's in the United Kingdom. It's from two good friends of mine, one Dr. Vandenbosch in the UK, and his data shows in almost 1,000 patients over the follow-up, only 2% of people required a revision. And the revisions were also notably quite easy to do. So this is an example, Dr. Aatif, my data shows MGB can be done well with now up to 20-year long-term outcome from the MGB in my hands, that it can be quite good. And so let's maybe go forward and we'll talk a little bit about the anatomy of the MGB, how it differs, and then how it applies to a revision of a sleeve. Does that sound okay?
Yes, sir.
Okay, so what is the MGB? It's not obstructive. So there are many people making a tight, narrow, obstructive, short mini gastric bypass pouch, and we think that's harmful and pathologic and recreates some of the problems of Roux-en-Y and sleeve and band and vertical banded gastroplasty. The idea of the MGB is the gastric pouch should be a callus gastroplasty. And those of us who are old general surgeons who used to do ulcer operations years ago, the callus gastroplasty is not designed to be obstructive. It's designed to be as normal as possible, an extension, a non-obstructive extension of the esophagus. And so what we'd like to do is imagine eating broccoli or an apple or a bite of sandwich. And what we'd like to do is have that patient swallow comfortably without obstruction down through the esophagus, through the EG junction, and into the gastric pouch. And then the gastrojejunostomy, we want wide open, not tight, narrow, obstructive. Again, I have Australian surgeons, Greek surgeons, many videos showing that they make a tight, narrow, small, obstructive gastrojejunostomy, and they will have more symptoms of reflux, nausea, and vomiting because they've created, again, a recapitulation of the lap band and the other obstructive procedures like the sleeve and the Roux-en-Y with the small, tight pouch. So my bias is we want a large, wide open gastrojejunostomy. If that's true, then the next question that often comes up by our surgeons, and I'm sure you know the answers to these things, but I'll mention them for our listeners. Well, how does the MGB work? Well, it works by dumping. It works by dumping. And many people will say it causes malabsorption. Okay, there's another misunderstanding. The MGB is not designed to be malabsorptive. In other words, if you measure fecal stool for fat, we don't want to find fat in the stool from the routine MGB. The reason is malabsorption used by, say, for example, the biliopancreatic diversion and the very long distal bypasses gets excellent weight loss, but ultimately leads to complications. And these complications can be deadly. So what we want is we would like to induce the dumping syndrome. And remember, we have two types. This is basic general surgery, type 1 and type 2 dumping. So we'd like to interdict, we'd like to interfere with Coca-Cola, ice cream, and candy by type 2 dumping. So if the patient decides, I'm hungry, maybe I will have something that is a little bit sweet or what I would call more junk food, they will have the experience that you all know about, which is hyperglycemia followed by a profound, in many cases, hypoglycemia, and punish the patient, aversive conditioning. So it moves the patient away from choosing foods like that. That's our goal. The other point is we'd like to have the food dump go directly into the small bowel and then have type 1 dumping. And this is where a large bolus of food, almost of any type, will pull water by osmotic pressure into the small bowel and give the signs and symptoms of partial or complete small bowel obstruction, which is, as you know, severe abdominal pain. So again, with these two techniques, not with obstruction, what we like to do is say, eat 6 small feedings a day, eat healthy foods, so fresh fruits and vegetables, high fiber foods, oatmeal, and pulses or beans, things like that, in small amounts will lead to that healthy, low calorie density, healthy diet leads to a good outcome. And so that's our goal. And that's the way the MGB works anatomically, and quite, I would say almost the opposite of the obstructive type procedures. So do you have any comments on that, or should we go on to then dealing with the sleeve?
Yes, sir, I agree with you in totality, whatever you said. And I think Shahbaz is getting eager to talk about his revision.
Well, you know you must suffer if you talk with Rutledge, because he will talk all day.
Yeah. Yeah, I remember that when you did the first ever MGB review call, and I had just one problem that you were the only one who was going to teach for 2 days, and I asked you, "Will you be able to go about that?" And you just replied, "Stop me." Dr. Rutledge is unstoppable.
That's right. That's right. So yeah, I can talk. All right. So now we have laid out a very good background. Now we deal with what is the surgical approach to revision of a sleeve where they have weight regain. First, some warnings. Remember that you have the previously operated stomach pouch, and what we have seen is that people are often tempted to re-sleeve the pouch. That is, their diagnosis is not the obstruction has failed, but the obstruction is not adequate because the pouch is dilated. So that the underlying physiology can be repaired by, quote, re-sleeve. And the published series on that look pretty good, but those series that say positive things are short-term. And what I have seen with friends of mine who talk to me around the world, including here in India and other places, re-sleeving is dangerous because it's not clear where the old staple line is. And you may have an ischemic segment when you're stapling to re-sleeve. And if that occurs, you may have a leak. And of course, the leak is the thing we fear as one of the worst things that can happen. So what we'd like to say is don't touch the gastric pouch. That's our first bit of advice.
Sir, your screen has frozen and your voice is also now breaking up.
Yes, and same for you.
Trying to change some presentations. And